everyone. Thank you for joining us on this month's wellness webinar. Today, we're going to be talking about prostate cancer, specifically understanding your options, prostate cancer treatments explained. Joining us is Dr. Douglas Woodman. He is our radiation oncologist. Dr. Woodman, thank you so much for being here. I will go ahead and hand it over to you.
Okay, terrific. All right, just a little thank you everybody for joining in today. My background, I went to medical. I'm from Galion, Ohio, so just an hour north of Columbus. So I grew up and ended up going to medical school in Cincinnati. And then I did my uh, internship, actually not at IU, I don't know why I put there, but I actually did my internship in central Indiana. And then I did my residency in this field, radiation oncology, at Indiana University Medical Center in Indianapolis. And I've been practicing radiation oncology for over 30 years now. So I've been doing it for a little while. But again, thank you everybody for attending. So what I really thought I would do in this presentation is talk with the audience just in the same way that I would with a patient that's coming in to see me, because just about all patients that I see for consultations are still trying to make a decision about what to do. And it's very confusing with prostate cancer because there are so many options. So I'm just going to kind of approach it in that fashion. So we'll put at the top here external beam radiation therapy. There's lots of different ways to do external beam radiation therapy. It has changed a lot over 30 years. Most of what we do in this department is what we call stereotactic body radiation therapy to do what's on the slide here, which is called extreme hypofractionation, which is just a fancy way of saying we deliver a lot of radiation in a limited number of treatments. The more traditional way of delivering external beam radiation is to do it more slowly in order to keep it safe. And nowadays, that's referred to as moderate hypofractionation. And usually that's about a 6-week course of daily treatments. Prostate brachytherapy is something that you may come across if you do any research at all online about radiation therapy for prostate cancer. Basically, this is loading the prostate gland with a bunch of radioactive seeds. And this is still being done nowadays, but I would say more often at academical medical centers. It is not being done nearly as much as it used to be out in the community. It is more labor intensive. I think that it's less forgiving. So if you're doing it, you need to be doing it on a fairly regular basis. The main appeal to brachytherapy in the past was that it's a single outpatient surgical procedure, and a lot of patients would prefer to do that instead of doing a long drawn out course of external beam radiation. But again, we stopped doing that here nearly 15 years ago once we got our CyberKnife machine, because it's really a much easier way of doing radiation. You may come across proton therapy. We get questions about proton therapy frequently. Proton therapy is a very fancy way of delivering external beam radiation therapy. There's really no advantage to proton therapy, but it is a very expensive tool to have in the toolbox. And proton therapy is more limited in its availability. Ohio State does have proton therapy now, and I think they've had proton therapy for maybe a couple of years. And I'm not sure how much they're using it for specifically for prostate cancer, but again, proton therapy is just another version of external beam radiation therapy. There's no particular advantage to using proton therapy. Um, yeah, okay. Next slide here. So, I mean, usually the discussion starts off with there's a decision point that the patient is going to have to make immediately, and that is, are you going to do, first of all, are you going to do treatment at all? Depending on the circumstances, sometimes patients will not do treatment. They'll go with the option of active surveillance, which simply means you're going to be monitored very, very closely, with the idea being that you may perhaps never need to do any treatment at all. Or at least you're able to postpone treatment for a certain period of time. So that's active surveillance. The next decision point is if you're going to do treatment, it's usually between either surgery or radiation, and not necessarily in that order. One or the other, surgery or some form of radiation. You'll see some other treatment options listed here. HIFU is high intensity focused ultrasound, which is a thermal effect on the prostate gland and the cancer. Another option here is cryotherapy, which is actually freezing the prostate gland and the prostate cancer. And then there's another option here, hormone therapy. So HIFU and cryotherapy, you will come across if you're searching the internet for treatment options. I think that HIFU and cryotherapy are interesting treatment options. They're still not on par with surgery and radiation. And the way I normally think of HIFU and cryotherapy are, they are options, sometimes they're options as a salvage treatment for a patient that goes on to have a recurrence after initially having something like radiation. And then hormone therapy is really not a treatment that's used to cure prostate cancer. It is a treatment that can be used to slow down prostate cancer in the right situation, in the right circumstances. If you have a older, much older patient that has a lot of other health problems, sometimes hormone therapy will be sufficient as a standalone treatment. It cannot cure prostate cancer, but it certainly can slow down the growth of prostate cancer. It's also sometimes used in conjunction with radiation therapy under the right circumstances to get a better chance of cure. So that's pretty much that. Oh, and then robotic prostatectomy. I usually try to give credit to our robotic surgeons by simply saying that in the right hands, this is an excellent option. It does, I think, need to be done by a surgeon who is extremely experienced. It is still surgery, even though it's done robotically. The idea of doing it robotically is that you can sometimes go home the same day or leave the hospital after a very brief stay. And surgery is a good option. There's nothing wrong with surgery. And absolutely, some patients, after investigating all the options, land on surgery, and robotic prostatectomy is the current standard of care. But I think that the operator, the surgeon, is critical when it comes to doing that treatment, because things can go wrong. And the big issues with both radiation and surgery, the big questions are, what are the chances that I'm going to end up having urine leakage, incontinence of urine? And what are the chances that I'm going to end up having erectile dysfunction? And those issues are on the table, both with radiation and surgery. But when it comes to talking about a prostatectomy, I do think it's critical, if you want to minimize the risk for urine leakage and erectile dysfunction, that you have a surgeon that has a proven track record.
Great. Thank you so much, Dr. Woodman. It sounds like there's several options. So we'll go ahead and open the floor to questions. But I also just wanted to remind everyone to talk to your doctor today about the risk and benefits of prostate screenings. If you scan the QR code, it'll take you to our page that has more information. So I'll give you a moment to scan the QR code with your phone's camera. And we'll go ahead and open the floor to questions. If you have any questions, please drop them in the Q&A section. Now, Dr. Woodman, I know we received some questions on our social channels, so I'll go ahead and read them to you. The first question we received was, can you explain how CyberKnife compares to traditional surgical options like radical prostatectomy or robotic assisted surgery?
And so CyberKnife is well, the name of the machine is CyberKnife. So that's a proprietary name used by the manufacturer. And it's unfortunate. It was meant to imply the precision of a scalpel, although it has nothing to do with the scalpel. It's just very, very precise radiation therapy. And so we have a CyberKnife machine here. It's a machine that does what we call radiosurgery. There are other machines that can do radiosurgery, but CyberKnife itself is a very unique piece of equipment. It's a radiosurgery machine that can be used anywhere in the body, from head to toe. Other radiosurgery platforms are not necessarily able to do that. And by having a CyberKnife machine here, we are able to do radiosurgery for prostate cancer. And at the end of the day, the comparison between radiosurgery, or let's say CyberKnife, and conventional external beam radiation or surgery like prostatectomy, it's just that CyberKnife is a very quick treatment course. It's a very convenient way of doing external beam radiation therapy. I think what impresses patients the most after we talked with them about CyberKnife is the holy grail with radiation therapy has been forever. How do you make sure the radiation only goes to its intended target so that you don't accidentally create some complications by having the radiation go a little bit too much that way or a little bit too much the other direction, and then you end up hurting the patient. All of radiation therapy has become much better through the years, so that we're able to do a very good job with that. But with a CyberKnife machine, you can deliver super enormous large doses of radiation and do it safely. And so at the end of the day, CyberKnife is just a convenience issue. It doesn't give you a better cure rate. It doesn't necessarily reduce the chances for side effects. It's just a more convenient way of doing radiation.
Thank you. And it looks like there's two questions about CyberKnife. So I'm just going to go ahead and kind of combine them into one. Is CyberKnife considered a minimally invasive treatment, and what types of prostate cancer are best suited for it?
All patients are eligible for treatment using CyberKnife. I think that's the simplest, easiest answer. So there's no particular type of prostate cancer patient that wouldn't necessarily be eligible for using CyberKnife. And the other, what was, oh, and I think the other question was, is it considered minimally a minimally invasive
Invasive. Yep.
technique. Yes, there's really the treatments are extremely simple. They take about a half an hour for each of the five treatments. Takes about a half an hour to do treatment, and the patient is lying on their back, and you feel absolutely nothing. It's a painless treatment, so it is minimally invasive. Now, I will qualify by saying that in order to use CyberKnife, we have to place gold markers inside the prostate gland. And we also insert a gel material between the prostate and the rectum. So we have to do that procedure before we get to the CyberKnife treatment. That procedure is very similar to the prostate biopsy, almost identical. But it's just either I place those markers in that gel, either I do that or the referring urologist, and it's done with a general anesthetic. It's an outpatient procedure, doesn't take very long, but we do use a general anesthetic. So that's invasive, but the actual CyberKnife procedure itself is just non-invasive.
Thank you. And then there's a few more questions. What are the risks of choosing active surveillance over immediate treatment? And how often are follow-up tests done during active surveillance?
Yeah. Um, so patients, my, my thoughts on active surveillance are maybe different than what a urologist might have to say about active surveillance. But I think the concept of doing no treatment is difficult to rationalize. I think unless a patient is older and with some health problems, where it is quite possible that you would never benefit from treatment for prostate cancer. If the situation is where a patient is relatively younger and in good health, I think the concept of postponing treatment is problematic. It What it usually consists of is just doing no treatment, and you're having your PSA monitored very frequently. I think at least every 3 months, and then periodically you will need to undergo a repeat biopsy. And I'm not real clear on the frequency of that. I used to tell patients that is done on a yearly basis. I don't think it's necessarily every year. It might be more like every year and a half. And then sometimes they're alternating repeat biopsies with MRI scans of the prostate. Uh, and but my comment on active surveillance basically is that it's it's tough for patients, I think, psychologically to do active surveillance because in the back of your mind you have this cancer that may eventually need treatment, and the entire time that you're doing active surveillance, you're giving the cancer a head start. You're giving it the opportunity to progress. And what happens with prostate cancer in most cases is that over years, over time, the cancer will become worse, the PSA will continue to climb, and then our chances of cure start to diminish. So the other thing I like to tell patients about active surveillance is that your best opportunity to have your cancer cured is now, because later on, it's not going to be the same as it is now. So and I think there have been studies, I think we're learning more about active surveillance as time goes by. Um, it has been in practice for a number of years now, but I think what some studies are finding, um, that the outcomes sometimes can be affected in a bad way. So I think the answer, in my opinion, is still out on active surveillance and how best to do active surveillance, and which candidates are actually most eligible for active surveillance. But it's troublesome for patients. I see a lot of patients that come in to see us who have first elected for active surveillance, and then eventually, after a couple of years, they've had enough of it, and then they come in and they decide to do treatment.
Got it. Thank you. And I see one question came in. It says 68-year-old with 2 years of 4.5 PSA readings. Just had an MRI, no results yet. Would you recommend a biopsy regardless of the MRI results?
Um, it sounds to me like maybe that's a patient on active surveillance, and if the first thing that comes to mind is if the PSA is remaining stable that whole time, if it hasn't really changed much, it starts to make you think that this might be a type of prostate cancer that may not ever need treatment. Because typically with prostate cancers, what you do see happen is the PSA does continue to increase. But in this situation, if the PSA is remaining stable, that might lead you to believe that it's a cancer that may not be um, of the aggressive type. And the other question about would you need a biopsy? I think sooner or later you will need to have another biopsy, and I think active surveillance does sometimes incorporate MRIs alternating with biopsies. But if the MRI is suspicious, um, I'm not sure what a urologist would recommend if the PSA is remaining stable. I'm really not sure. If the MRI comes back and is not suspicious, if it's reassuring compared to like if there have been prior MRIs, my guess is that would give them more reason not to recommend a biopsy. I think the only time that they would jump in and do a biopsy with this repeat MRI is if your PSA is rising or if the MRI looks suspicious.
Thank you. And then the last question that we have for the webinar is, how do you recommend that I prepare mentally and physically for treatment?
Hmm. Oh boy. How psychologically and physically prepare? I've never thought about that question before. And I think it's hard to know what to tell someone about that if they haven't been in those shoes before. All I can say to that is that it's unbelievably easy. I think, based on my experience and talking to thousands of patients who have gone through this, it's a piece of cake. It's patients when they've finished this course of treatment, they usually are surprised at how unbelievably easy the whole process was. So I guess I would try to reassure the patient that this is not like cancer treatment that you hear about that's going to make you sick or ill or cause you to be in bed and not be able to do your normal routine. The only thing that can happen when you're going through radiation treatment, whether it's CyberKnife or otherwise, is that you certainly can and probably will experience temporary urinary side effects. So that means for a few weeks, you're going to be making more trips to the bathroom to urinate. So frequency of urination, maybe some urgency of urination, maybe a slower stream. This goes on for a few weeks, but then it's temporary. It completely clears up. It completely goes away.
Okay, thank you. And I'm so sorry. There's one more question that someone submitted. So I'm going to go ahead and read that out to you. Can you have radiation CyberKnife after ultrasound treated prostate cancer for a rising PSA with no evidence of disease on radiology assessments?
Yes. So uh, can can and do we treat patients who have already previously been treated? I'm guessing this patient might have had. They're probably referring to HIFU, high intensity focused ultrasound. And yes, we do see those patients that have recurred, and yes, we do treat them. Um, And usually the scenario is, how do we diagnose a recurrence after high intensity focused ultrasound? The PSA is steadily rising. And the only other question that comes up is, does that patient need to have a repeat biopsy at that point? And that's up for discussion. That's controversial, not necessarily. But yes, the answer is yes. We can do CyberKnife to treat a patient who has a recurrence after having undergone previous HIFU.
Great. Thank you. That is all the questions for today. If anyone joined just a little late, you will receive an email with these slides, so you'll be able to access them. And you can also go to mountcarmelhealth.com/webinars to view this webinar and our past ones. But Dr. Woodman, thank you so much for taking time to speak with us today and sharing your expertise. I hope that everyone learned something new. And again, thank you so much for joining us. I hope everyone has a great week.
Thank you.
Bye-bye, y'all.